He gives the truth and nothing but the truth.
I do.
Good morning, sir. Could you please tell us your name?
Mustafa Hammand.
And what is your profession?
I'm a neurologist and interventional pain physician.
Okay, and where's your practice located?
1931 North Cove Boulevard, or Martin Luther King Jr. Boulevard.
And that's here in Panama City?
Panama City, Florida, 32405.
Okay. My name is Les McFadder. I'm with the firm of Perry & Young, and I represent a lady by the name of Kimberly Page, who I understand has been a patient of yours in the past.
Yes, sir.
This has to do with a slip and fall incident that happened on August 2nd of 2014 at a Dollar General store out on Panama City Beach.
Yes, sir.
Are you aware of that incident?
Yes, sir.
Okay. Before we get into your treatment and evaluation of Ms. Page, for the benefit of the jury, could you tell us a little bit about your profession, your education, your training, things like that?
Yes, sir. I finished my medical school back in 1999. Then I did my residencies in internal medicine and neurology, and then fellowship. And now currently I'm board certified in neurology and psychiatry, interventional pain management, sleep medicine, and neurophysiology. I practice at the Neuromedical Institute that I established myself back in 2007. And where we focus on 3 specialties: the neurology, interventional pain, and sleep.
Okay. And do you hold any current licenses?
Florida license and Georgia license.
Right. And those are licensed physician, medical doctor?
Correct.
You mentioned board certifications. Could you tell me again, what were the different board certifications that you hold?
Well, I started with the internal medicine 10 years ago. It's expired, so I'm retaking it again to be recertified. That's why I did not mention it in May. But I'm board certified in neurology and psychiatry, pain management, which I'm retaking every 10 years I have to update it, so I'm retaking it in April. Interventional pain, sleep medicine, clinical neurophysiology.
All right. Now, is every physician that practices in those areas, is every physician board certified in those areas?
If you really want to practice these specialties, then it's preferable, yes, sir.
So in terms of becoming board certified, is that a matter of just sending off an application and a check, or is there actually a process involved with the board certification?
No, sir. There's a long process. It can involve residency, a fellowship, and occasionally grandfathering into the area, but you have to submit your qualifications. You have to submit extensive CMEs, continuing medical education, training, and also you have to get a recommendation from colleagues in the same field. And at the end, you sit for a board, and you have to pass the board to be able to be certified. And every 10 years, you have to renew your certifications.
And a board is a test or an exam?
Correct.
Okay. Do you hold any privileges at any of the local hospitals?
Currently, no, sir.
Okay. In the past, have you held privileges at the hospitals?
Yes, sir.
Which ones?
Bay Medical, which is currently Sacred Heart Hospital, Gulf Coast Hospital, Health South, and it used to be Bay Behavioral too.
Okay. Now, a lot of the services that you provide, are those provided at your own facility? Do you have the ability to provide a lot of these pain management, sleep study, treatment protocols at your own facility?
Yes, sir.
Okay. Let's talk a little bit about Miss Page. I understand she was a patient of yours.
Yes, sir.
When did you first see her?
November 25th, 2014.
And how did she come to be under your care?
It was referred to us.
Who referred her to you?
Dr. Rohan, I believe.
Okay. What specialty is Dr. Rohan in, if you know?
Orthopedic surgeon.
Now, when Miss Page came in, you said November 25th, was a medical history taken from her?
Yes, sir.
What did that medical history include?
The time of the accident, the nature of the accident, the symptoms that she had,
Okay.
and the previous treatments that she received.
And what did she tell you about the incident itself in terms of what happened, how it happened, and what her symptoms and problems were?
At the time, I'm sorry.
You can answer. What did she tell you in terms of how everything occurred and what her problems were?
At the time, she stated that she slipped and she fell down on her buttocks. And since then, she has been complaining of lower back pain and buttocks pain, predominantly on the right side.
Okay. After taking a history, was a physical exam conducted?
Correct.
And what did the physical exam involve?
At the time, she had severe tenderness over the right piriformis area, moderate over the right SI area, and mild over the lumbar paraspinal muscles.
Okay, so right piriformis,
SI joint,
right
sacroiliac joint, and the lumbar paraspinal muscles.
Okay. What is the piriformis muscle? Where is that located?
The piriformis is a large muscle in the buttocks area that connects between the sacrum, which is part of the spine, and it connects to the trochanteric bone, which is basically part of the hip bone. The function of the muscle is to externally rotate the leg. So it plays a big part in terms of leg movement and predominantly turning the leg to the outside.
Now, when somebody complains of pain in the piriformis and there's I guess, a diagnosis of piriformis syndrome, what is piriformis syndrome?
Essentially is a piriformis dysfunction. Essentially, the muscle is dysfunction, could be inflammation, is not working very well, is pinching a nerve. So that's usually typically the definition of the syndrome.
Okay, and you also mentioned SI joint or
Yes,
sacroiliac joint. What is that?
So the SI joint is a large joint that is in the same area in the buttocks, essentially where the spine sits on the pelvis. So this is a weight-bearing joint that holds the entire weight of the body above the pelvis. It is connected by large ligaments, and it's a mobile joint. Essentially, it allows the spine with the pelvis to be flexible when you walk or you move.
Okay. And if there's a dysfunction or a problem with the SI joint, how does that typically manifest itself?
Typically, the classic presentation can vary, but in general, the classic presentation of a SI joint, what we call SI joint dysfunction, is a pain in the buttocks area, which is the lowest part of the back. That is a lot worse when you stand and walk. It gets better if you take the weight off of it, meaning if you lay down. That's the predominant. At times it can radiate down, but for the most part it stays over that area.
Okay. And then the remainder of your exam also revealed some issues with her lumbar spine.
Correct.
All right. And tell us about that.
It's basically she had some tenderness over the lower part of the lumbar spine on palpation.
Okay. So once you did your physical exam and came up with these findings, what was your proposed course of treatment for Ms. Page?
Yes, sir. So as a interventional pain specialist, my first job when I evaluate a patient is identify what I call the pain generator. Because now as an interventionalist, I have to intervene and specifically treat a specific pathology. So the first, essentially, we try to identify, and that's why we propose these three areas of pain generators, because the treatment can be different. With her, based on the examination, the history, the predominant pain was with the piriformis. There is a component of the SI joint, and there's also some component of the lumbar. But in order of what would be causing her pain the most, probably the piriformis SI, then the lumbar area. So at that time, because she has already been seeing physicians receiving chiropractor therapy, massage therapy, she has taken medication, she's still in pain. So we suggested an intervention. I use the intervention essentially to localize, to diagnose and treat. So I call it the diagnostic and therapeutic intervention. And we offer to start with the piriformis injection for diagnostically and therapeutic.
Okay, so looking at your treatment plan, you're basically focusing on three areas: the piriformis, the SI joint and the lumbar in that order.
Correct.
And the first order of treatment was an injection into the piriformis muscle?
Yes, sir.
Right. Tell us, how do you go about doing that injection, and what's it designed to do?
Yes, sir. So again, the piriformis is a muscle in the buttocks. It connects the sacrum and it connects to the hip joint, essentially, around the hip joint. We do the procedure it can be done under ultrasound or fluoroscopy. In our office, the preference is fluoroscopy. I find it better and easier. We basically, a fluoroscopy is a live x-ray. The fluoroscopy is a guidance of the needle to know exactly where the needle is at all times. So the patient is essentially laying supine, meaning on their stomach. And under fluoroscopy, we identify the landmarks. The landmarks is going to be a bone landmarks and not the muscle, because the muscle you don't really see it. And essentially, we numb the skin over the area. I go to the lateral aspect of or 1/3 of the muscle, which is on the outside of the muscle. Don't go in the middle. And the reason is because the sciatic nerve is there, and I try to avoid it to avoid numbness of the sciatic nerve or the leg. And under the guidance of a fluoroscopy, we use a spinal needle, which is a long needle, which is 3.5 inches, and we advance it until we touch the bone. So essentially, that's that's the area where the muscle is. I draw out about 1 centimeter off the bone, because the muscle is off the bone. And at that point, I inject the desired medication. And what we injected at the time is a combination of pivivacaine, which is a numbing medicine, and dexamethasone, which is a cortisone, a mixture of both, 12 cc's of that.
Okay. And once that injection was performed, is there immediate relief, or do you have to wait and see how it affects the patient? What do you do next?
For the most part, because it has a combination of an anesthetic and a dexamethasone or the cortisone, so we expect, and this is not necessarily always, but we expect an immediate relief within a few minutes. That might last for hours, because this is the effect of the lidocaine. And then and it can last up to 2 to 3 days too. And then you have the effect of the cortisone or the dexamethasone that we use. That can be within a day, 2 days, and can even up to a week before you see the full effect, depending on the patient, depending on the pathology, depending on how bad the inflammation or the area is affected.
Okay, so once the injection is performed, you're going to give it a little bit of time to see how it takes effect, but then do you have the patient come back and provide you with a report?
Correct.
Right, and then what did Ms. Page report to you in terms of how the piriformis injection made her feel?
Initially, she said it did not help, and that is basically the initial impression for patients, because they expect it to work quickly. And I believe on a follow-up visit, she stated that it helped temporarily for about 2 to 3 days.
Okay. Now, you mentioned this injection as being both a treatment tool, but also a diagnostic tool.
Correct.
Right. Diagnostic meaning you're trying to determine if this is actually the source of her pain?
Correct.
What did the piriformis injection and how Ms. Page reported back to you how it felt, what did that tell you?
It really confirmed my suspicion from the initial visit that her main problem, probably the piriformis. The question is, the initial immediate response confirms that. The lack of long-term response, probably due to the chronic nature of the problem, that it did not work.
Okay. So based on how Ms. Page responded to this injection and this initial treatment protocol, how did that change or alter your overall course of treatment for her? Or what did you decide to do next?
I have to look back on the notebook, because at some point we also offered to do an SI joint injection. I'm not sure the exact timing or the date for that. And the reason is because also from the initial visit, we thought that some of her pain is coming from the SI joint. So we wanted to address that too. And we did an SI joint injection on her.
All right. Was there any other testing that was ordered?
On the initial visit, we also did we ordered a nerve conduction test too.
What is a nerve conduction test?
A nerve conduction is basically there's two parts to it. It's called a nerve conduction and an EMG or electromyography. This is a two-part test. The purpose of this test to directly and indirectly look at any pinched nerve in an extremity. The nerve conduction part of it, essentially, we stimulate the nerve with electrical shocks, and then we record from the muscle. That would be a direct study of the nerve itself, the integrity of the nerve, if it's being affected by being pinched or by having any disease that is affecting the nerve. Then the second part is the EMG, where we take a small needle and insert it in the inside specific muscles. Each muscle in the extremity is supplied by a nerve. So essentially, if the nerve is diseased or affected, then you're going to see the effect in the muscle. Because the nerve, let's say in the leg, if we're studying the leg above the knee, is very deep. So it's going to require us a large electric shock or high electric shock to stimulate it. So indirectly, we study the muscle, and that will give us the same idea that there is a pinched nerve at a specific level from the origin of the nerve, which is the back, all the way down to the toe.
Okay. You mentioned the term extremity. Is that arms and legs?
Sorry, yes, sir.
That's okay. And in terms of the nerve conduction test and the EMG, nerve conduction EMG, is that an objective test?
Correct.
Right. Tell the jury what's the difference between objective and subjective.
Yes, sir. So a subjective symptom or a subjective test is essentially what the patient is telling you. So that is dependent on the story of the patient. An objective finding or an objective test is a test that the patient cannot essentially alter. They cannot fake, they cannot change, because it is all dependent on the test itself to determine the results.
Other types of objective tests include MRIs, X-rays?
Correct.
Prior to coming to see you, had Miss Page, were you aware of the fact that Miss Page had an MRI of her lumbar spine?
Yes, sir.
Do you know what that MRI, what did it show?
It showed that she had some degenerative changes, essentially from L23, L34, L45, L5S1, but also at the L5S1 there is a disc that is toward the right side, pushing the L5 nerve root.
Okay. So you've done nerve conduction testing,
Yes,
and what did the nerve conduction testing
It
reveal?
showed that she had what's called chronic reinnervation changes, which is basically a chronically pinched nerve at the S1 on the right side.
Okay. And when you say chronic, what does chronic mean?
Essentially 3 months and longer.
All right. So this would have been roughly 4 months or so after the incident at Dollar General.
Correct.
Now, once you did the nerve conduction study and had the benefit of the MRI that was taken prior to Miss Page seeing you, how did that alter or change or affect your treatment plan, if at all?
Yes, sir. So essentially, again, we go back to the pain generator of us as a physician identifying the pain generator, and that is done by three different tools. One is the symptoms of the patient. The second one is your physical examination. The third one, any supporting diagnostic tools. So as we said, is basically we had the piriformis, the SI, and the lumbar area. So with having the S1 nerve is pinched on the right side, and then we having the findings on the MRI that she has the L5 S1 disc is pushing on the L5 nerve root on the right side. We entertained the idea of let's focus a little bit on the disc at the L5S1, and therefore we ordered the decompression therapy.
Right. And what is decompression therapy?
So decompression therapy is essentially a tool that allows that treats discs or pinched nerves. The concept behind it is that it's a huge or a big table that the patient gets harnessed on the table and becomes part of the table. The table is connected to a computer, and we can program essentially which disc that we want to work on. The idea behind it, which is essentially that the table either tilts depending on the table, or there is a pull with the harness that the harness will tilt. And essentially the pull becomes on an angle. This is totally different than traction, where that is or traditional pulling in physical therapy. This one, actually, the pull becomes on an angle. The purpose of having the pull on an angle is to focus the pull on the disc that you want to work on. The pull itself is very mild, so it's not really severe that patients sometimes might not even feel it. If they feel it, just a mild pull. The idea behind the pull is to create a negative pressure between the two vertebrae. The negative pressure creates two phenomena. One is a suction phenomena, which essentially the negative pressure, now you have a disc that has a negative pressure in it, so it's going to start sucking back in its place, essentially. We have patients that completely went back in its place. We have some patients that moved slightly. In my opinion, any movement can give you relief from that pain, because you just need to get off the nerve even by 1-2 millimeters and the pain is gone. And the second phenomena that creates something called osmosis, which is a chemistry phenomena. Essentially, if you have a negative pressure within a compartment, then the high concentration area will move into the negative pressure. So you have nutrients and fluid move from outside the disc into the disc, so the disc becomes healthier. And the purpose of it is to give you pain relief that is specifically generated from the disc.
All right. Now, in Miss Page's case, was the decompression therapy focusing on that L5, S1
Correct.
section of the spine?
Yes, sir.
All right. Is the decompression treatment, is it something that is done one time only, or is it a course of therapy that extends over a period of time and a number of visits?
The protocol that we have is 20 visits. It is done either daily for 5 days a week until you finish them, or typically the protocol that we have and use for her is the first 2 weeks is daily for five sessions each week, and then it goes every other day for the second 2 weeks until, and then once a week until she's finished with them. So, but the 20 sessions total.
Okay. Now, once Miss Page completed the decompression therapy, what did she report back to you? Or I guess what were the results of that therapy?
So essentially, clinically, she did not see significant improvement. But we repeated an MRI, and sometimes we do this to see if there is any changes in the disc itself. And the MRI showed some improvement. So from an MRI standpoint, there is an improvement. From a clinical standpoint, there is no significant improvement. Essentially, we benefited from this treatment that is supported the initial idea and thought that her pain generator is really coming from the piriformis and lower than the actual L5-S1 disc.
Okay, so based on those findings, did that alter or change your treatment protocol for Miss Page?
I'm not sure, honestly. I have to look at the chart to see. We did an SI joint on the patient, so I'm not sure if was done before or after the decompression therapy. But at some point with her, we just elected to proceed with the chronic pain management, which is essentially just medication.
Right. Now, you mentioned the SI joint injection. Tell the jury how that's performed and what you hope to accomplish when you administer that sort of treatment.
Yes, sir. So again, this is an interventional pain procedure that is done under fluoroscopy. And a fluoroscopy is a live x-ray. The patient lays on their stomach. And the joint is very large joint, easily to identify under x-ray. And basically, after identifying the patient on the joint under x-ray, we use same spinal needle, which is about 3.5. It is a 3.5 inch long. And under the guidance of the live x-ray, we advance the needle until we go inside the joint. The joint has a capsule, so you can, as a physician, you can feel the joint going through, the needle going through the joint. And essentially, we inject the same medication, which is pivivacaine, an anesthetic, a numbing medicine, in combination with a dexamethasone, which is cortisone. We inject a small amount, about 2.5 cc inside the joint. It doesn't take more than that. and then the rest of it, which is about 5 cc, we injected on top of the joint to soak the ligament. As I stated, this joint is large joint, is covered by a large ligament. The pain can be generated from destabilization of this ligament, and therefore with this injection we target the ligament and we target the joint itself. It can give you an immediate relief. Again, the same concept that can last for hours to days, but the full effect we expected to see after a week or so.
Okay. Do you know how Ms. Page responded to the SI joint injection?
I believe at the end it did not really provide her with any relief.
And what did that tell you then?
We go back to the same concept that I think the piriformis might be the guilty factor here in her pain generator.
Okay, so you've tried these different injections, you've done decompression therapy, and at some point, I guess the other treatment option that could be offered was the pain medication.
Correct.
And that is something that Ms. Page was started on?
Yes, sir.
Okay, tell us about the medications she was prescribed and what they were for, and really how she responded to them.
I'm not sure in terms of the chronological order of what she's been on, but at some point we prescribed hydrocodone. We prescribed what we call NSAIDs, which is the anti-inflammatory from the ibuprofen, naproxen family. She was prescribed the Flexeril, which is a muscle relaxant, just to try to relax the piriformis itself. We sent her back for chiropractor therapy. We sent her back for also massage therapy.
Now, when a patient is taking these pain medications, why would you also send them to physical therapy or chiropractic therapy? What's the point of
Yes, sir.
Of that?
So, again, in my opinion, in medication overall in a chronic state does not cure. It does not get rid of the problem. That's number one. Number two, I try my best not to rely on one modality as pain medication, because when you put someone on a pain medication really for a chronic period of time, essentially you're committing them to the pain medication, but you're not taking care of their main problem, the source of their pain. And that's why initially we started with interventions, because my goal with her is to get rid of her pain, correct the problem that she has, and get her back into life. So we believe, we are a strong believer of what we call multidisciplinary approach to pain management, which is, I think it is more effective than just utilizing one modality. And that would include the massage therapy, the physical therapy, the chiropractor, interventional procedures, and medications. But our goal with a lot of our patients, if we can succeed, is to get them off the medication, correct the problem, and correct their issue.
From a non-invasive standpoint, and by invasive, obviously, I'm talking about surgery or sticking needles in people.
Yes, sir.
From a non-invasive standpoint, treatment of the piriformis muscle or piriformis syndrome, is that something that is routinely done through chiropractic and physical therapy and massage? You can answer.
Yes, sir. So I always say, I mean, pain management is an art. Each artist, pain physician have their own style. Yes, I mean, physical therapy, chiropractor therapy, massage therapy are considered non-invasive. So that's really essentially, if I may say, guidelines, essentially the normal approach to patients when we get them into pain management. We have to make sure that we did the non-invasive modalities before we move into a more invasive. I mean, injections are not necessarily invasive, but they're more invasive than physical therapy or massage therapy. And of course, the most invasive is surgery. So yes, and for the most part, the non-invasive therapies should be attempted at any point, and sometimes repeated to make sure that it has failed in treating this patient.
Did Ms. Page ever relay to you how the medications that were prescribed, how they were working or how they were affecting her?
I mean, Ms. Page, in general, I mean, the medication helped, but she had always concern that she doesn't want to be basically on medication. She is a teacher. She's always expressed the concern that really she's hesitant to be teaching kids while taking those medications. but at the same time, she's in pain, and she needed to take something to be able to be treated.
Okay, so did Miss Page ever beyond the concerns about having being on medications while teaching, did she ever relay to you how her overall condition, her pain condition was proceeding at this point? I mean, 'cause you treated her over a period of several years.
Yes,
Correct?
sir.
How did her overall condition and her quality of life, how was it affected, or how did she relate to you that it was affected?
So, I mean, I clearly remember the visits that we had with Miss Page. I mean, she's really, I mean, she presented herself as very concerned. I mean, she's in pain. She most of the visits, as a matter of fact, she keeps moving from sitting down to standing up, changing position because she was uncomfortable. And at the same time, I mean, she wanted to get back into her life, but she can't because of the pain. So we were at a tough position. That's why with her, I tried a lot of different things to try to get her out of her pain and get her back into life. So yes, the pain has affected her life dramatically.
Now, you mentioned at the beginning of this testimony that you did take a history from Miss Page.
Correct.
And you're aware that that history included a history of anxiety and depression.
Correct.
In your experience as a pain management physician, who is also board certified in psychology or psychiatry, what does a chronic pain condition typically do to somebody who has a pre-existing issues with anxiety and depression? How do you see any sort of interplay between those two things?
Just to make a correction, so I'm board certified in neurology. The board itself is called neurology and psychiatry,
okay.
But essentially neurology with a component of psychiatry.
Okay.
So
okay.
that I'm not pure psychiatry board certified.
Sure.
That's a different board. But to answer your question, I mean, we have a lot of patients. I mean, pain changes your life. Pain changes your family. Pain changes your existence. So absolutely, pain has a dramatic psychological effect on patients and their family. Pain can cause depression, absolutely, because especially it is most from my experience, and I speak my opinion, it is most prominent and effect on active patients who are outgoing, they have a life, they're young, and suddenly they can't do what they used to do because of the pain. So yes, that can cause anxiety and can cause depression, and which we as pain specialists or being a neurologist, we have to address. And a lot of our patients are on anxiety medications and antidepressants while we're treating their pain.
Right. Now, did Ms. Page ever mention to you any other sorts of effects it had, such as problems with sleeping or problems with her normal activities?
As I said, I mean, when she come to our office, I mean, she would never sit still because any position, although the most part of it is sitting, the seating position is the worst. But yes, the pain, as she experienced that pain even at nighttime, she's uncomfortable. That caused her some also insomnia.
Right. Now, at some point, Ms. Page put in an application for leave under the Family Medical Leave Act from her job as a teacher. Were you aware of that?
Yes, sir.
Right. Do you know why she put in a request or why she was seeking medical leave from her job?
I believe it was two reasons. The first reason is she was in pain and uncomfortable doing her job. And the second part, the concern that she's taking medications that might affect her mentation while teaching kids.
Right. Did you support
Yes, sir.
her request for that medical leave?
Yes, sir.
Now, as a pain management physician who, as a part of your treatment protocol, prescribes medication to people, do you require drug testing of those patients?
Yes, sir.
Did you require drug testing of Ms. Page?
Yes, sir.
Was Ms. Page compliant with your drug testing policy?
I mean, with the policy itself, yes. I mean, she gave us the drug test every time we asked for it. But at some point, her drug test came back negative.
Okay. Now, early on in the treatment, were there any discrepancies or any issues with her drug test?
No, sir.
Showing any sort of non-compliance any sort of drugs or medications that she was not supposed to be taking?
No, sir.
All right. Now, toward the end of your treatment, you mentioned that the tests were coming back negative.
Yes, sir.
All right. Do you know why that was?
From what she told us, that she's not taking her medications
Okay. Did she tell you why?
because of the fear of being addicted to those medications and affected her mentation and life.
Okay. I anticipate you're going to be asked on cross-examination about an admission to the hospital, so I'm going to go ahead and ask you about it first.
Yes, sir.
Were you aware of the fact that Miss Page self-admitted herself to Gulf Coast Medical Center in November of 2016?
Yes, sir.
Do you know what that admission was for?
That she's going through withdrawal symptoms for opiates.
Right. Was that also around the same time period that her drug tests with your office were coming back showing she was not taking any medication?
I believe so.
Right. Is it common for somebody who has been taking pain medications over a long period of time for chronic pain for them to come off the pain medication? Is withdrawal, is that a common occurrence?
Yes, sir.
Right. You're aware of the fact that she went to Gulf Coast Hospital and that was the diagnosis?
Yes, sir.
Right. One of the things that they did at the hospital was they ran a drug panel.
Yes, sir.
On Miss Page as well. Are you aware of that?
Yes, sir.
One of the findings of that drug panel was amphetamines.
Correct.
Are you familiar with the medication phentermine?
Yes, sir.
What is phentermine?
It's a medication that used for, it's an amphetamine type or family class that is used for weight loss.
Okay. Are you aware that Miss Page had been prescribed phentermine by her family doctor?
Yes, sir.
Right. Do you know what it was prescribed for?
Weight loss.
If somebody gives a drug test and it comes back positive for amphetamines and they're on phentermine, do you have an opinion as to what that positive finding is from?
From the weight loss medication that they're taking.
All right. The record itself from Gulf Coast Medical Center actually indicates amphetamine abuse. Do you agree with that finding based on what you know Miss Page's history to be?
No, sir.
You were aware of the fact that she was taking phentermine while she was under your care and taking the pain medications?
Yes, sir.
If somebody violates your drug testing policy by taking medications they're not supposed to be taking, what do you do?
Essentially, I mean, it depends on really what it is. It's a complex policy in terms of the urine drug screen and what we regulated. But if let's say if we find amphetamine, as long as we have a prescription and we have documentation that this has been prescribed by another physician, then it's fine with me. It doesn't interfere with what we do. But if we cannot generate that, and then we find out that this could be obtained from off the street or from someone else, then at that point we taper off the opiates and we don't prescribe opiates. We just manage them with non-opiates modalities.
Now, in this case, Ms. Page had decided herself that she wasn't going to take any more opioid medication.
Yes, sir.
Right. So, was she still in pain at this point?
Yes, sir.
So you have a patient that you've tried injections. You've tried decompression. She's receiving chiropractic, physical therapy, massage therapy. You've tried pain medications, and none of these things seem to really be helping her cure her problem, correct?
Yes, sir.
When you have a patient like that, what sort of treatment options could you recommend for them going forward? I mean, is there a range of treatment options that could be recommended?
Okay. I always tell my patients, and I stand by this, I've never actually went back on my word to my patients. I never give up on a patient as long as they don't give up on me. We always can find ways. We start with the conventional, we start with the simpler, and then we proceed to do either non-conventional treatments or some other treatments that might help them. So with her, the idea, honestly, that she responded to the piriformis injection, but not for a long period of time, it gave me an indication that that might be the main source of her pain. So I suggested personally, I suggested a platelet-rich plasma as a next option, which is it's called PRP, as a next treatment for her.
Okay, and you also talked about conventional treatment. What would the conventional treatment be? Is that the massage and the...
Whatever we've done with her, it's just the medication, the massage therapy, the possible chiropractic therapy, physical therapy, and then steroid injections.
Okay, so you recommended PRP. What is that, and how is that administered?
Yes, sir. So for a long time, we've always thought that platelets function is for blood clotting. That's why we take the aspirin and the Plavix to prevent blood clots. But it turned out that platelets are a lot more important in our body than blood clotting. And one of the functions is basically to relieve inflammation in the body. They actually signal to the stem cell. The stem cells are the main source of cells in the body that actually come in and build the new cells, so they can counteract, they can treat, cure the inflammation. So essentially the platelets produce substances, many of them, called cytokines and interleukins. So essentially the cytokines are signals. There are different types. One will counteract inflammation, and one will also signal to the stem cell to leave the bone marrow or the fat cells, wherever they're hiding, to come and rebuild the area. So essentially, let's talk about Mrs. Page, or Miss Page, that she had a problem in the piriformis. So what is the problem? It's inflammation, really. It's a damage in that area. So already from the time that the damage started, the platelets are already working to come into the area, to produce those cytokines, to clean up the inflammation, to resolve the inflammation, at the same time producing other cytokines to the stem cell to come to the area and say, let's build whatever damage. The problem is when the damage is severe, or the damage is chronic, that we did not take care of it, then the platelets are unable to do this. It's just too much for them. So with the PRP procedure, or the platelet-rich plasma procedure, we help the body do this. How we do this? We take a large volume of the patient's blood. It's about 60 cc's, sometimes more depending on how much we want to treat. And really, it's very simple. We just basically spin it and isolate the platelets. So the first spin, we get rid of the red blood cells. The second spin, we concentrate the platelets. So now typically the number of platelets in our body is about 200,000 per cc. But now with this system, we can concentrate it and increase it to 2 million per cc. So you can imagine this is 10 times the amount of platelets that would be working in that area. And then we take it and inject it where the problem is. The first 24 hours, the pain might increase because we're actually irritating the area. We're inducing what we call controlled inflammation, that more platelets and blood will come to clean up. And within a week, the patient starts seeing improvement, because what it does, it really gets rid of the inflammation and starts signaling stem cell to come in and build where the damage is. We give it about 6 weeks to see the full effect. Within 6 weeks, we should see, and for the most part, it is about 80 to 90% success that we see the full effect. At times, we have to repeat it twice. I usually give my patients twice. Some physicians might do it up to 5 times to get rid of the inflammation, depending on how bad it is and how long it's been there.
Now, if the PRP is not successful, what is the next step you could offer?
The next step, what I call, is the big gun, which is the stem cell. As what we talked about, the platelets signal to the stem cell to come in and build. They really build new cells. So, but when the problem is too much, they still even cannot be enough to do that. So what stem cells are, we're all created out of one stem cell. And this stem cell gets differentiated into eyes, brain, skin, bone, so all the cells that make up our body. So those stem cells are hiding inside the bone marrow and between the fat cells, and mainly in the abdominal fat. And every time you have a damage, let's say I have a cut in my arm or my hand, I lose cells. So the stem cells come in and start differentiating to build a new skin cell, a new muscle cell, a new vessel cell. So what we do with this procedure is essentially, when the problem is too much, it cannot keep up with it, we help the body heal itself. So we take a volume of bone marrow, if we choose the bone marrow, depending on which area, what we're treating, or we can take a volume of fat from the belly or from the buttocks. So it's essentially liposuction. And we have a system that can isolate the stem cells and concentrate them. And again, it concentrates them 10 to 20 times of what we have in that sample. And simple, we just go and do the same procedure as what we've done with the cortisone, but instead of injecting the cortisone, we inject the stem cells. We mix it with also PRPs to give even better effect, and we mix it in the area. That process or that injection will take about 6 months before you see the full effect, because essentially you are building new cells in that area.
Now, given your understanding of Miss Page and her injury and her condition, PRP and possibly stem cell is something that you might recommend for her as future treatment.
Absolutely.
Now, if I understand correctly, there's really, in terms of future treatment options, there's really 3 that are available for her.
In my opinion, and my experience, it's going to be the massage, physical therapy, or she goes back to the medications, which she's resisting to do that, and then she goes to the PRP or the stem cells.
All right, let's talk real quick about the massage and the physical therapy.
Yes, sir.
Is that going to provide her with a permanent, lasting relief?
No, sir.
Is that something that, based on her condition, her injury as you understand it, is that something that will require a lifetime of maintenance if that is the route she chooses to proceed?
Yes, sir.
Right. So we have a lifetime of that, or we can try the PRP and the stem cell.
Correct.
Now, if we try the PRP and the stem cell, is there a guarantee that it's going to cure her?
Nobody can guarantee any therapy, no matter what it is.
Right.
We do our best.
All right. But those are essentially the 3 treatment options for Ms. Page.
Yes, sir.
Right. Would you defer to her chiropractor, physical therapist, as to the costs of those temporary massage, myofascial release procedures that they would offer?
Yes, sir.
Right. Now, as for the PRP and the stem cell, is there a cost that goes along with that type of procedure?
The PRP is about $1,000 for each session, and for the stem cell is around $5,000 for each session.
Okay. And do you have any idea or any opinion, within a reasonable degree of medical probability, how many PRP sessions, how many stem cell sessions might Miss Page require, given the chronic nature of her pain and her injury?
Yes. Essentially, I personally, for my practice, I try 3 PRP sessions. If she gets excellent relief, we just leave it alone. I have some patients that might require it on a yearly basis. They come and get it, and it's really benign procedure because you're just getting your own blood. We're not adding anything. For the stem cell, we do it once. In 6 months, she gets what's called a PRP booster, where basically it gives her more effect, and it might be repeated in a year and 2 years. So the PRP might receive multiple injections.
Okay, so if you're thinking a recommendation of at least 3 PRP injections and 1 stem cell, we're looking at a cost of about $8,000 for that initial treatment. Is that correct?
Correct.
All right. And if it has to be repeated over a course of years, it would just be a multiplier in regard to that, correct?
For the PRP, yes, sir.
Okay. Not for the repeat of the stem cell.
The stem cell, for the most part, I sometimes I repeat it, but for the most part is a one-time thing. But at times, yeah, in a couple of years we might repeat it.
Would it be reasonable medically to anticipate that Ms. Page might benefit from PRP injections on an annual basis after this initial treatment?
Yes, sir.
And would that be over the course of her lifetime? Or would there be some duration that you would kind of draw a line at?
Really, it's a tough question to answer for the most part. Again, I don't draw a line. I mean, and I don't give up on a patient. So whatever it takes. But if one time a year PRP took care of her pain for that year, I think it's a reasonable thing to do. There's really no side effects other than the needle stick from the procedure. Is she going to require this? Possible. I can't really confirm.
Okay. So in terms of forecasting, and the reason I'm asking this is because the jury's going to have to make a determination as to what they think is reasonable for future medical care. We have an opinion as to what the massage and the chiropractic would cost. What I'm asking for is your best assessment of what you think would be reasonable for the PRP and stem cell forecasting into the future, the cost of that.
Again, I mean, she would require 1 stem cell, possible repeating it in 2 to 3 years. She would require initially before the stem cell one PRP with the stem cell. She would require a PRP in 6 months as a booster, and possibly once a year, at least for the next few years.
Okay. Now, given what Ms. Page related to you about how the incident occurred, do you have an opinion with any reasonable degree of medical probability as to whether her injury is causally related to the incident at Dollar General on August 2nd, 2014?
It is.
Okay. Do you believe her injury is permanent?
Yes, sir.
If Ms. Page opts to go with the chiropractic myofascial release procedure, maybe because she doesn't like needles, do you have an opinion as to whether or not the elective of that type of treatment would be reasonable given her condition?
Yes, sir.
Okay. Do you charge for your time?
Yes, sir.
Do you charge patients for the treatment that's provided to them?
Yes, sir.
Right. Now, over the course of the past several years, Ms. Page has received a wide variety of treatment from your office: diagnostic testing, MRIs, X-rays, nerve conduction testing, physical therapy, chiropractic, decompression, interventional pain management. All of those types of treatment, they carry a cost with them, correct?
Yes, sir.
Right. Now, according to your billing records, it looks like the total charges for Ms. Page's treatment at their Neuromedical Institute is $41,496.88. Is that correct?
Yes, sir.
Are those charges reasonable and in keeping with the charges from other providers located here in Bay County that offer similar services?
Yes, sir. I think our office, because we provide a lot of ancillary services within the office, might be even cheaper.
Okay, because you're able to perform
Everything is under one roof in our office. Yes, sir.
versus having to go to a surgery center and incurring an extra charge there. Are your medical records and your billing records, are they generated at or near the time that the service is rendered?
Yes, sir.
And are those records kept and maintained within the ordinary course of your business?
Yes, sir.
And does the content of the records and the bills, do they accurately reflect the services provided and the charges incurred for those services?
Yes, sir.
Have all the opinions you've expressed here today been done so within a reasonable degree of medical certainty?
Yes, sir.
Right. Dr. Hammand, what I'd like to do, and we may need to coordinate this with the court reporter, is I'd like to attach a copy of your chart as Exhibit A, a copy of your billing records as Exhibit B, and I don't have any more questions.
Yes, sir.
Thank you.
Thank you, Dr. Hammand.
You're very welcome.
My name is Justin Ross, and I represent Dollar General.
Yes,
Thank you for appearing today. I have the unenviable position of coming in after, so I may jump around a little, so I apologize for that.
Oh, no, please.
And so let me reverse already back to the beginning and ask you a little bit about your background. What medical school did you attend? And when you said you graduated in 1999?
Yes, sir. It's been a while. For medical school. I did my undergrad at the University of Pittsburgh back in 1994, I believe.
Okay.
And then I attended medical school at Lake Erie College of Osteopathic Medicine, and also where I obtained my DO degree, and I got my MD degree too from University of Health Sciences, Antigua.
Okay. And you've testified at trial before?
Yes, sir.
How many times, have you testified at trial?
Are you talking about live trial or depositions?
Well, obviously we're not in trial right now, though this may be used. How many times live at trial? If you know?
I haven't been to a trial for live for clinical cases.
Okay.
It's all depositions, yes, sir.
And how many times have you testified at a deposition?
Numerous times.
Okay. More than 100?
Probably.
Okay. More than 200?
I don't keep a track of them.
Okay.
I will stay safe at 100.
All right. And on those cases, do you testify both as a treating physician and as a expert physician?
Predominantly treating physician.
Okay. And do you, in those instances where you've testified, have they been any personal injury claims?
Yes, sir.
What percentage of the cases, if you can, that you testified in were personal injury cases?
Probably for the most of them.
Okay. Do you also testify in any worker compensation claims? Or
Yes, sir.
what about disability claims?
I haven't.
Have you ever testified as a defense expert in any cases?
No, sir.
So it's always for the patient or the plaintiff?
Correct.
Okay, and as a pain management physician, pain specialist, you are involved in prescribing pain medications?
Yes, sir.
Have you had ever had any investigations by either the DEA or the Florida Licensure Board as a result of the?
No, sir.
Okay. Okay. You mentioned about having drug tests every so often
Yes, sir.
on patients that you're prescribing pain medications. Do you do them at the same course through all patients, or does it depend on the patient how often you would do the drug
Depending
test?
on the patient, of course.
Do you monitor patients who you're prescribing pain medication to closer if they have a history of mental health treatment?
It depends on the risk of the patient. I mean, if the patient is giving us a reason to monitor closely, we do.
Were you aware that Ms. Page had a history of mental health treatment?
Depression and anxiety, yes, sir.
Are there any, you mentioned obviously the lab tests that you do, if there's something that comes up on there that you're not expecting, that would be a red flag?
Yes, sir.
Any other, well, let me ask you, if someone is having issues with the law enforcement, arrests and stuff, would that be a red flag as towards medical or the drug prescriptions?
Depends for what reason. If it pertains to pain medication or drugs, yes. But if it pertains to something else, we just basically study case by case to if it's going to affect their pain management or not.
Now, during the course of Ms. Page's treatment, if you know, were there any red flags that were raised about her pain medication prescriptions?
No, sir.
Again, sorry to jump
Oh,
around,
no,
but
please, by all means, that's fine.
did you do anything in preparation for your deposition today as far as review any of your records?
Yesterday, I did reviews my chart in my office. Today, before the deposition, we also reviewed the records today.
And as far as records, are you referring to the records that you generated from, or you or your office generated?
Yesterday, yes, sir. It's all my notes. Today, no, from I was shown some records here too.
What records were you shown today?
The hospital admission records, and there's also a second opinion or a medical expert records. I'm not sure the name of the physician.
And those were shown to you by Ms. Page's attorney?
Yes, sir.
And you met with Ms. Page's attorney before your deposition today?
Yes, sir.
How long did you meet with him?
30 minutes.
Did you meet with him prior to today in preparation for deposition?
No,
Did you speak with him prior to today in preparation for
No,
deposition? Did you review any MRIs or X-rays in preparation for today?
Just from yesterday's report, yes, sir.
And that would have just been the reports
Correct.
from those?
Yes, sir.
Okay. Now, you were asked on direct about how you obviously charge for your time
Yes, sir.
with patients and also for giving testimony in procedures like this.
Yes, sir.
What is your fee for coming in to appear for deposition?
I honestly don't know the exact number, but I mean the check, but I have not even looked at it. If
Do you
want
get
me
paid hourly?
I believe so. I'm not sure. My office usually takes care of that.
Okay. Were you paid separately to meet with Ms. Page's attorney prior to deposition today?
No, sir.
Okay. Yeah. Again, apologize for jumping around,
No,
but we were
please.
talking about your board certification
Yes,
earlier, and you testified that you're board certified in neurology and psychiatry, and you were kind of giving some clarification later that you were board certified more on the neurology side of that. have you ever been an or I guess found to be an expert in psychiatry?
No, sir.
Okay. Do you, as you sit here today,
No, sir.
suggest that you're an expert in psychiatry? Okay. Okay. All right. Let's talk a little bit about Miss Page and the treatment that you did
Yes,
with her. Now, it looks like you first saw her November 25th, 2014.
correct.
Okay. And it looks like the last time she was seen by your office was in January of 2017.
Yes, sir.
Okay.
And let me just confirm that, so just to be accurate. Yes, sir. January 12th.
And I think, and we'll let the jury if they want to count them, but I think approximately 21 visits altogether in that two plus years period. Would that be fair to say?
Sure, I didn't count them. But
Okay. Would you disagree that of those visits, you only saw her 9 times?
I didn't count them, but
Okay.
the records will show.
You have other physicians or
Correct.
other either PAs or physicians in your office who see patients, correct?
Correct. Yes, sir.
And so you don't see the patient every time that they come in.
No, sir.
And I know we talked about, or you were asked on the direct, and Mr. McFadder phrased it in a way that you've been seeing her for a long time since the August 2014 incident, but it's in fact been 2 years out of the last 4.5, 5 years, correct?
Correct.
You indicated in your direct that after your kind of initial exam and taking the history, you had these concerns about the piriformis, as well as the SI joint and then the lumbar paraspinal muscles.
Yes,
okay. And as a result, one of your diagnostic and therapeutic treatments was to do the piriformis injection, correct? Okay. And you actually testified on direct that Ms. Page's initial reaction that it did not help, correct?
Yes, sir.
And in fact, she said it actually made things worse.
Initially, yes, sir.
Okay. But then you indicated that at a subsequent treatment appointment, she indicated that it had provided some relief for, I believe, 3 days.
Correct.
Now, and if you need to, I can point to the
Sure.
record, but it was actually when you saw her on January 15th, 2015, based on seeing her after that initial piriformis injection, you actually recommended that she have another piriformis injection, a repeat piriformis
Yes,
injection, correct?
Yes, sir.
And in fact, during the course of treatment, this is January 2015, so you saw her for a whole another 2 years until January 2017. Ms. Page had no other piriformis injections. You also, in direct, you talked about how you take different steps, non-invasive first to try to determine where the problem's coming from. And I believe you at sometimes recommended doing a transforaminal epidural injection.
Yes, sir.
Would that have been something to do a diagnostic therapeutic
Correct.
treatment?
It would be both.
And Ms. Page never got one of those,
Yes, sir.
did she? It looks like, and you've recommended that on more than one occasions. Is that correct? That
Yes,
you
sir.
had recommended Ms. Page have that
Transforaminal.
transforaminal epidural?
Yes, sir.
Okay. You also, and this may be the same thing, I apologize, I'm not
Sure.
a doctor, but it also looks like you, at one point, Ms. Page was recommended an interlaminar epidural. Is that similar to a transforaminal, or is that just a different location?
Almost, but different. A transforaminal focuses, it comes from one side and it focuses on one nerve root or two nerve roots, multiple nerve roots. But with the interlaminar, it comes in the middle and you cover all of them from the inside.
And you had recommended that at one occasion, correct?
Yes, sir.
And Ms. Page never had that done.
Correct.
In fact, the only other injection she had during the 2+ years of treatment was the SI joint injection that you referred to.
Yes, sir.
So she, now sorry, you talked about how another course of treatment that was the pain medication, correct?
Correct.
And I don't want to put words in your mouth, so I want to make sure I state this correctly. But was your testimony that you usually do the diagnostic injections first to see whether pain medication, or is it a duo approach?
There's really no guideline or specific approach. It can be done before or after or at the same time.
Okay, and in Ms. Page's case, she was prescribed the hydrocodone, the Norco, on the first appointment that you saw her in November of 2014, correct?
Yes, sir.
So she was getting pain medication prescribed basically during the entire course of your treatment.
Yes, sir.
And that was both the Norco and the Flexeril, correct? Now there was, and again, if you need, it sounds like you reviewed your records, so you're pretty on top of it. But if you need me to direct you to the date, I can. But there was during the course of treatment where you recommended and prescribed Neurontin
correct,
for Ms. Page.
Yes, sir.
But she didn't take that medication, correct?
I believe she did, and she had some sedation or some sleepiness from it. But I'm not. I have to look in the record and confirm it.
Now, if your records on subsequent appointments had indicated that she was not taking the Neurontin, would that?
Yeah, that would confirm.
Okay. Now, hold on. I think you also prescribed a medication called Grelease.
Which is Neurontin extended release.
Okay.
And that's why I thought she might have had side effects to the Neurontin. We switched her to the Grelease because it has less side effects. Patients who have side effects to Neurontin, or the other name for it is gabapentin, then we go to Grelease, which is an extended release taken once a day instead of 3 times a day with the Neurontin.
Okay. And do you know if she ever took the Grelease?
I can't confirm that.
And you don't know if she even took the Neurontin
I can't
and had
confirm it
it
100%. No.
Now, during the course of your treatment, I believe you initially prescribed the Norco at 5 milligrams.
The initial one is 7.5, sir.
And then, well, I think that you're correct on the November, but then I believe
Yes.
the subsequent appointment on December 16, 2014, the prescription of Norco of 90 tablets was 5 milligrams.
I can confirm it in a second, but if it's stated, then that probably correct.
Well, during the course of her treatment, it appears that you initially prescribed Norco at 5 milligrams, and then it was increased to 7.5, and then in 2016 it was increased to 10 milligrams.
Correct.
Okay. So, and when we're talking milligrams, does that mean the dosage or
Correct.
the intensity of the
The
pain
dose.
medications increased?
The dose.
Okay. And each time you prescribed the Norco, was she prescribed 90 tablets
No, I mean, it started at 60 tablets and it then went up to the 90.
to 90?
Yeah. Yeah, I have the medication history now. It started at 7.5 twice a day. And then we went down to 3 times a day, or 7.5. Then we cut it down to 5 milligrams 3 times a day. And then eventually went up to 10 milligrams 3 times a day. And the Neurontin has been prescribed several times, so I'm not sure. I mean, I'm assuming that she took it based on the prescription.
But if
So-
the records indicated that she was not taking it,
Possible. I can't confirm it. Sorry.
okay. During the course of your treatment and the prescription of the pain medications, did you ever have any suspicions of any dependency on the medications? As far as Ms. Page?
Yes, sir. Yes, sir. So, in general, I mean, I did not see any red flags or any aberrant behavior from her. But in general, I mean, those are narcotics and opiates. Patients, they're going to develop tolerance and they're going to develop a dependence. We hope that they don't develop addiction. So there's a difference. So the nature of the beast of the medication is not in the control of the patient. That the tolerance is defined as the body gets used to it, so the body requires a higher dose to get the same effect. That is the nature of the beast. That's not in the control of the patient. And dependence, also the nature of the beast. That's not control of the patient, which basically the patient, the body, not the patient, the receptors, the opiate receptors in the body depend on the medication, meaning is that it cannot be stopped abruptly. If it's stopped abruptly, you're going to go through withdrawal. So that's also an opiate nature. It's not a patient that controls it. And then you have the addiction, which is basically the patient take it for the wrong reason because it makes them feel better. And they don't take it because of the pain, they just take it because it makes them high, essentially. So these are three different terms that are, even physicians mix them up and patients misuse them in different situations, just to clarify what they are.
Now, would if someone's continuing to take pain medications with no objective findings, would that be an issue, an instance that would maybe be a red flag to dependency?
If there, I mean, essentially, this is difficult position to be placed in as a physician. Yeah, we actually try to play the guardian for the patient and at the same time the police for the patient, because I'm not going to prescribe the medication to someone that don't need it. So before we even prescribe opiates, and that's why we use a multidisciplinary approach. So it's not all about the opiates. We try other modalities, other techniques to make sure that, or even before that, we have to confirm that there is a pathology. We have to correlate the patient's symptoms. As a neurologist or pain specialist, I know the anatomy. I always say I'm a human mechanic, so everything has to fit. If this wire does not connect with this wire, this pipe does not connect with this pipe, that means something wrong. So as a physician, that's what we refer to essentially as localization or pain generator. I have to confirm, does the pain that the patient is describing subjectively correlates with objective findings and exam findings, that, let's say, performance syndrome. It gives a specific symptoms. So if the patient coming to me and giving me symptoms that are totally different than a performance syndrome, then I say there might be a question mark if these symptoms are correct. But if the patient's symptoms, and they don't know what a performance syndrome, they've never heard of it, but it correlates and they're describing a performance syndrome, and on my examination, it is definitely the symptoms are a performance syndrome, then at that point, you would love to have an MRI or another objective finding that can support it, but you don't necessarily get it all the time. But you have to make a judgment as a physician that yes, the patient's symptoms are real because they correlate with what I found on my exam, and maybe it correlated with another objective test like a nerve conduction or an MRI that can also put it together. At that point, I start treating the patient. And at that point, I also offer multiple things, because just confirming it and giving him opiates, that's the wrong thing to do from a pain management, because it's not going to correct the problem. So you go in terms of other modalities.
Right. And in Ms. Page's case, though, you had prescribed the opiates on November 24th, 2015.
Correct. And the reason is because I did not prescribe the opiates and send her home and say, okay, this is your medication and we're done. I outlined a treatment plan. But to get to the treatment plan from authorization, from scheduling, I can't leave the patient without something to relieve their pain until I get to that point.
And we talked a little bit about it earlier, but as far as like the diagnostic testing, you only did the 2 injections, correct? The 1 piriformis injection and the
therapeutic and / diagnostic, but correct. Predominantly therapeutic.
But there's just those 2
correct.
injections, yes, correct? And then you brought, while we're talking about objective findings and the MRIs, you mentioned the MRI and so prior to your treatment of Ms. Page, you had reviewed the MRI that Dr. Rohan ordered, correct?
Correct.
And you, I believe, testified on direct that based on your review of that MRI, you determined there was degenerative changes in the upper lumbar region, I believe L2 through L4.
Correct.
But that there looked to be an acute finding at L5, S1 with regards to a bulge in the disc, irritating the nerve root of L5.
Oh, touching. Not the word irritating is more of a symptomatic, but it's touching the nerve root. Okay. Yes, sir.
Okay. Now, you at some point during your treatment, you ordered a subsequent lumbar MRI
after decompression therapy.
Right.
Yes, sir.
That was in October 19th. On October 19, 2015, that you had the second MRI done.
If it's stated that, then that's probably the date. I can't relate in.
Okay. Well, let me If need be, I can show you the record. But did you have a chance to review the? Well, first off, the MRI was done at your center.
Yes, sir.
Okay.
Correct.
And you had a chance to review the results of that MRI.
Correct.
Okay. And as far as L5S1, this subsequent MRI of October 2015, it showed that there was no significant disc disease there, correct? I can show you the record if that can
Please.
help you. All right.
What date are you looking at again, Justin?
October 19th, 2015. That's the MRI. And I guess once you have the chance to review that, can you read actually for the jury what the impression was at the L5S1?
Well, the impression is the L5S1. I'm sorry.
Yeah, I'm sorry. The findings, I should say.
Only the L5S1.
Correct.
Is no significant disc disease. The nerve root appeared to exit without compromise. The AP diameter of the thecal space measures 15 millimeter.
And that's a change from the 2014 MRI as far as the L5S1.
Correct.
Correct?
Yes, sir.
And it showed that it resolved.
It's correct. And that's what decompression does.
There's no longer any nerve root touching, at least from that MRI, correct?
Correct. Yes, sir.
Yep.
Well, let me just, if you don't mind, just to read something else
Okay.
from the MRI.
And is it direct? And I'm referring. And I'm
L5S1.
It's talking about the L5S1.
Yes, sir. Because, and I'm not sure why this happened, but because there was an addendum that was added to the report. When a radiologist add an addendum, that means there was a question asked by a clinician. I don't remember that I asked it personally, to take a look again at the L5S1 because of the previous MRI showing that there's a disc touching the nerve root, and therefore they take a look at it again. And let me just to state that.
So
Yes, sir.
So
Please.
based on that, you said you asked for them to take it. It
I
appears
don't-
that you did.
I don't recall, and to be clear, I don't recall if I asked or one of my physicians asked, but according to the addendum, it says previous images were made available, and that's probably what happened, is that they sent them the old MRI, and now they compared the two MRIs. And it says there appears to be no significant change in the degenerative disc since the previous study. There is a minimum encroachment of the L5 nerve root on the right. However, the nerve root on the more recent study appears to exit without compromise. So that indicates they confirm that there is, but it's better. But it's not that there's no significant change. And I can give it to you, that first addendum. Oh, and let me just to state why would this happen is because MRIs, I mean, I look at images a lot of times. MRIs, I mean, it's dependent on the radiologist that read them or the physician that read them. So essentially, there are subjective reads. So I might take a look at an MRI and say, you know what, it's not significant, and there is something. And as a clinician, sometimes if it doesn't fit clinically with what I see with the patient, because the radiologist does not see a patient, it only sees the image. So they can read specifically the image. But as a clinician, sometimes I correlate them that the patient has a symptoms that are indicating that it's something wrong with the L5 nerve root. So I can, my sensitivity to looking at the MRI increases. And that's probably what happened. So to take a look at it, or took a look at it again and showed that there is a disc, but it's better.
And this MRI that we're talking about, October 2015, that was done in your office.
Correct.
Okay.
Yes, sir.
Now you talked earlier on direct and talked a big deal about wanting to use the diagnostic testing that you have to determine where the problem is.
Correct.
And you in fact did a pelvic MRI as well, correct?
Yes, sir.
And would it be fair to say that based on your based on that pelvic MRI that you did in November of 2015, you felt that you needed to do a subsequent MRI because with better contrast, because it was not real clear?
Yes, sir.
Okay. And in fact, you had recommended that Ms. Page have that subsequent pelvic MRI so you could see what was going on with the piriformis area?
Yes, sir.
Okay? But she never did have that subsequent MRI. And the reason you wanted to have that second pelvic MRI so you could better see the piriformis area, correct?
Correct.
Now, you were asked on direct. Counsel brought out, and you indicated that you were aware about it, about the admission to Gulf Coast Medical Center in November of 2016 for, well, their thing said amphetamine abuse secondary to narcotic withdrawal.
Yes, sir.
Okay. Did you know about that prior to meeting with Ms. Page's attorney?
No, sir.
Okay. So Ms. Page never advised you of having to go to the emergency room for narcotic withdrawal during the course of your treatment.
I don't recall, to be honest with you.
Okay. And now I'll represent to you that admission was on November 6, 2016. And in looking at your records, I don't believe it was you, but someone from your office saw Ms. Page on November 17, 2016, so 11 days after that hospital admission.
Yes, sir.
Okay. And on that November 17th, 2016 appointment, Ms. Page was prescribed Norco and Flexeril again, correct?
I have to go back to the record, but if it is in the record, it is, yes, sir.
Okay. So 11 days after she's going to the hospital for drug withdrawal, she's being prescribed pain medication again, correct? In fact, the last time she was seen at your office on January 12, 2017, she was prescribed Norco and Flexeril again, correct?
Yes, sir.
Okay, you talked a little bit on direct and talked about the PRP, the plasma, well,
Platelet-rich plasma.
thank you.
Yes.
That treatment procedure, correct?
Yes, sir.
And you indicated it was about $1,000 to do it?
Correct.
Okay. In fact, during the course of your treatment of Ms. Page, you had recommended doing that treatment, correct?
Yes, sir.
Okay. And Ms. Page declined it.
Correct.
Okay. Now, in direct, you talked about how the next step would have been the PRP treatment, and if that didn't work, then the stem cell, correct? And so when counsel says that she would have a PRP and a stem cell treatment, that's not accurate. She would only, in this scenario, which didn't happen because she didn't have any of that treatment, but in this scenario, if she had the PRP treatment and it was successful, she would not have the stem cells.
Correct.
Okay. And again, we talked a lot about that treatment on direct, but she didn't have any of that,
No, sir.
correct? In fact, you recommended the PRP and she did not go through with it.
Correct.
Now, if I can, well, let me ask you, doctor, you and I have your records, and the jury is going to have a chance to see your records. You maintain records in your office,
of course.
and it's important for the treatment records to include anything that's going on, updates in examination, updates as to Ms. Page, anything that's relevant to her treatment that goes into those records?
Yes.
Okay. And so anything that Ms. Page would have advised you about her condition and about her treatment, that would have something that you probably would have put in the records, or
Yes,
your
sir.
office is trained, if it's not you who saw her, but the PA, to put that in your records?
Yes.
I can show you, or if you on your computer can go to the June 29th, 2016 record, and I have it if it's easier to
That's
show you.
perfect.
Yeah.
Thank you.
And I'm just going to give you a minute to read that, and I just have a couple questions about it.
Yes, sir.
Okay. Is there anywhere in that record where it talks about Ms. Page being in a motor vehicle accident on June 1st, 2016?
No, sir.
Okay. Did you recall Miss Page ever telling you that she was in a motor vehicle accident on June 1st, 2016?
I don't recall. No, sir.
Okay. Is that, if she had told you that, would that something you would have put in your
Of course.
treatment record? Now,
Can I, if you don't mind, there's a follow-up sheet also that on top,
Oh, yeah.
to see if she wrote it there to herself or not, because that's a history that the patient gives.
okay, and this is a,
Same date?
yeah.
Just-
And what I'm showing you, that would be the form that Miss Page would have
Correct. Yes,
written
sir.
out before you treated her on June 26, 2016? I'm sorry, June 29, 2016.
Yes, sir.
And so she has an opportunity there to write in her own handwriting how she's doing, any new symptoms. In fact, it says, please list all new symptoms and complaints,
Yes, sir.
any changes. And that's something she fills out.
Yes, sir.
And is there anywhere in there where she talked about being in an accident 3 weeks earlier? Did she ever tell you that she was, were you ever made aware that she was well, let me strike that. Again, sorry to jump around.
Oh, that's all right.
Now, you indicated that Miss Page at some point came to you and told you that she was going to take medical leave,
Yes, sir.
right? And this was in 2016, correct?
I believe so.
Okay. And so this is 2 years after you, approximately just less than 2 years after the incident that we're here on today of August 2014.
Yes, sir.
Okay. Did she talk to you about taking medical leave at any point prior to 2016?
I don't recall. No.
And you indicated that one of her reasons for wanting medical leave was she was concerned, or strike that. I'll ask it this way. You indicated that she voiced to you that she was concerned about being on the medication while with her job as a teacher with young children, correct?
Correct.
Okay. And was that part of the reason that she was seeking the medical leave, or that's just something she had voiced concern to you?
I think the main reason is also the pain, that she's in a lot of pain, that she can't continue to work.
Okay. But when you first started treating her and when she was initially prescribed the hydrocodone in November of 2014, through that whole year up until 2016, did she voice any concerns about being on medication as far as teaching the children?
I don't recall that.
You were also asked on direct about, and I'm going to mispronounce this, but phentermine, the diet drug?
Correct. Yes, sir.
Okay. If that was something that Miss Page was taking, would that have been shown in your lab report?
Correct.
Is that something that when you see her in your examination, well, let me ask it this way. When you see her on your examination, do you follow up with what medication she's taking each time you see her, in case the primary care prescribes something?
Correct. Yes, sir.
Okay. And so if she had been prescribed phentermine and had advised you about it, it would be in your records?
Oh, yes, sir.
Okay. It looked like, and I can pull to the date, but it looked like there was one lab result where you got a positive test for ketamine. Do you recall that?
Amphetamine, you mean?
No.
Ketamine? I don't
Ketamine.
remember.
Okay. Is that something that you recall happening with Ms. Page?
No, that I'm aware of. No, sir.
Okay. Now, in addition to treating Ms. Page, were you asked by Ms. Page to assist in her disability application?
I don't recall that.
Do you recall receiving information from the Department of Florida Health in October of 2016 to either provide information or complete information in support of Ms. Page's disability
I don't
application?
recall. Personally, I don't recall, no, sir.
Okay. But it is something that's in the records?
It will be in the records, yes, sir.
Bless you.
Bless you.
Now, at one point during the course of your treatment, Miss Page was seeking to go to the Mayo Clinic.
Yes, sir.
Okay. And was that something that you encouraged?
Yes, sir. I recommended that.
Okay. And was that partly because you could not determine where the pain source was coming from? And you
No,
wanted
because
to-
she's still in pain despite what we've done. So I wanted a fresh opinion, and I gave her that option. I always give that option to patients that we're still not 100% taking care of or getting somewhere with their treatment.
Now, as far as Miss Page's condition after January of 2017, January 12th, I believe was the last appointment, do you have any opinion on her condition since then?
No, sir.
Okay, you've not treated her since then?
No, sir.
You've not seen or examined Miss Page in preparation for your testimony
No,
today?
sir.
I have no further questions. Thank you, Doctor.
Doctor, just a few very brief follow-up. Mr. Rost mentioned about the transforaminal and the interforaminal epidural injections that were offered at L4, L5. Is that something that's typically used to treat piriformis syndrome?
No, that's used to treat disc disease.
Right. And Ms. Page,
Radiculopathy.
Ms. Page has piriformis syndrome.
Correct.
Right. So the fact that she declined an injection that wouldn't necessarily address the problem she was having, do you have a problem with that? Is there an issue with that?
No, there's no issue. As a matter of fact, I mean, everything that we offer for patients is the choice of a patient. I always say my job is to offer you what options are there, guide you through it. It is your decision. We have many patients that say, I don't want this treatment, I don't want this treatment, I want this treatment. As long as it's within the reasonable guidelines and reasonable things of what we do, then that's fine.
Well, I believe the suggestion was that Ms. Page was somehow non-compliant because she didn't want to get an injection that you just testified wouldn't even be used to treat what you believe she has.
And no, I mean, she had a fear of needles, which is reasonable. And we had 3 pain generators, so we suggested that it could address the disc pain and not the piriformis pain.
And ultimately, the decompression therapy seemed to resolve
The disc problem, yes,
the
sir.
disc problem. Okay. The June 1st, 2016 motor vehicle accident that Mr. Ross just referenced to you, I apologize, I don't have a paper record, but I have pulled the note up on my computer. Do you have the note?
No, object to you reading it.
All right, well,
the
jury's going to get to see the record. I can either read it to you, or how about I do this? How about I let you read the context of the onset and then the what the patient actually told the doctor, since I don't think you were given the full scope in the question that was asked to you about that subsequent motor vehicle accident.
So the patient states that her sciatica pain is no different than usual.
What does she complain of from that accident?
Initially, this is the ER. The chief complaint is extremity pain.
All right, what extremity?
The patient complained of a burning sensation and bruising to bilateral forearms and wrists.
All right.
And left scapular discomfort.
All right. Now, you're treating her for
Buttocks
piriformis
and-
syndrome,
yes.
buttocks. And what does she say about the low back pain, the sciatica pain that she was dealing with?
The patient states that her sciatica pain is no different than usual.
All right. Now, the next visit to you was 28 days later, correct? I believe it was
Yes, sir.
June 29th, 2016. So 28 days after the motor vehicle accident was the next time she saw you.
Yes, sir.
And she doesn't say anything about the accident. If your records are correct, she doesn't say
No,
anything about
then
that
it's
motor
not.
vehicle accident.
Yes, sir.
She, do you know if the bilateral forearm pain that was caused from that accident, do you know if it had resolved by that time?
Possible,
All right.
she didn't mention it.
Do you have any heartburn over the fact that a patient neglects to tell you 4 weeks after the fact that she had not been involved in an accident that had no change or no effect whatsoever on the conditions that you were treating her for?
No, sir.
The ketamine question that was asked you weren't shown the record. Can I direct you to your visit of 10/13/2016?
Yes, sir.
Look at the second paragraph under plan. And could you read that for me?
Urine drug screen done today to ensure medication compliance per protocol. We did have a positive ketamine in the urine from August. The patient does get a compounding cream with ketamine in it. I discussed this with the representative of the and the pharmacist, and they state on comprehensive urine analysis, it may show up in there.
Okay, so Miss Page was given a compounding cream that was prescribed to her,
Correct.
and it had ketamine in it,
Correct.
and that would show a positive result on a drug test,
Yes, sir.
and that was something your office verified.
Correct.
And because of that verification and because it matched up with the history, again, that's not a violation of your drug policy, is it?
Not at all. That's compliance.
That doesn't even suggest to you that Miss Page is somehow abusing ketamine. There's a perfectly logical explanation for it.
Correct.
Do you know why she did not go to the Mayo Clinic?
I believe that the Mayo Clinic did not want to get involved because there is a litigation for the case, and her insurance will not cover. I think it has to do with insurance issues, but not that she did not want to go.
Are you telling me that a physician doesn't want to get involved in litigation and have to sit for a deposition sometimes?
No, I don't think it's a physician. It's more of a policy. In big institutions like this, it's a policy of the institution that they don't deal with these cases. They have the right to accept certain insurance or not their insurance. So, and probably they give her the option to do everything cash, and if she can't afford it, then she elects not to go.
Right. So the fact that you recommended her going to the Mayo Clinic, but she didn't actually go through, that's not her fault.
No, sir.
Okay. That's all I have.
Just a brief follow-up, doctor.
Yes, sir.
Well, first off, about the ketamine. In question on that, there's no suggestion that there was some abuse, because I saw that it showed that there was a cream thing. My question was that if there were other medications used, such as Phenerin, just like the ketamine, that shows up on your lab results, correct?
Yes, sir.
Now, you were asked about the transforamino and intraforamino epidural injections, and counsel in his question indicated or represented that those might not have been necessary because you believe the piriformis was the main culprit, correct? That's what counsel seems to be suggesting.
Yes, sir.
Okay. Now, you did the piriformis injection of Miss Page on November 26, 2014, correct? The day after you saw her the first time.
Yes, sir.
In fact, you had recommended that she have more piriformis injections, but she didn't want to have those.
Correct.
Okay. Now, and again, let the records speak for themselves, but the piriformis injection was on November 26, 2014. You recommended the transforaminal epidural or interlaminar epidural injections on March 3rd, 2015, March 31st, 2015, May 18th, 2015, June 8th, 2015, October 21st, 2015, November 2015, and December 2015. That's 1, 2, 3, 4. That's about 7 separate occasions after the piriformis injections where you recommended that she have the transforaminal injection, correct?
Yes, sir.
Okay. Now, if you thought that that wasn't something that could help her or that it wasn't related to that, would you have kept recommending that she have the injections?
No, sir.
Okay. Now, you were asked about the hospital treatment, and you were read some of the record. Were you aware? Well, strike that. Let me ask you this way, doctor. You treat a lot of patients who've been in car accidents,
Yes, sir.
okay? And so you have some experience of seeing people who have been injured in car accidents?
Yes, sir.
Okay? There's a lot of times they may not. Have you had the experience where a patient of yours did not report injuries to her back or neck at the first hospital occasion, but it came a day later or a week later?
Yes, sir.
Okay. Now, have you had the experience, in your experience of dealing with accident victims, if someone slammed into the car in front of them going 35 miles per hour, do you think that may cause some aggravation or injury to your back?
It can.
Now, in dealing with accident cases, because you said you have some, if you're the person who drove the car and rear-ended someone, you don't have an insurance claim, do you?
Probably not.
Okay. I have no further questions. Thank you.
No questions?